Today I am supposed to speak entire syllabus in 1 hour. The rheumatology is the subject, and the rheumatology, there is a DM course in rheumatology. It takes 3 years to learn, and that I am supposed to talk in 1 hour. So, how difficult and how painful for me is that I will have to discuss everything. So, I am not going to discuss everything because it is not possible. Now, the first question is, what is rheumatology? Anyone can volunteer. What is rheumatology? You can give the answer, right answer, wrong answer, doesn't matter. Hey, last bench বসার কোনো scope নাই. Any one person who hasn't come to the front. And the last backbencher, that girl, please come forward. The last bench girl, you understand Bengali or Hindi or English? What do you understand? Or you deaf or dumb? I do not know. Now, any one of you can say what is rheumatology and what it handles. Rheumatology basically handles issues of the 3 systems: musculoskeletal system, vessels, autoimmunity, and autoinflammatory diseases. So, there are 4 varieties of diseases, and they are basically musculoskeletal disease means usually joints and joints related diseases. In pediatrics, we usually call it a juvenile idiopathic arthritis. Then the vessels, that is vasculitis, and autoimmune prototype disease is SLE, and autoinflammatory I will not discuss anymore in the undergraduate course. So, in pediatric age group, if you are not going to become a pediatrician, then you will day-to-day practice, you will handle the vasculitis part most commonly, and the juvenile idiopathic arthritis you will come across. What is vasculitis? It is the inflammation of blood vessels, and we all know in the body there are 3 varieties of blood vessels: small blood vessels, medium sized blood vessels, and large sized blood vessels. So, you can have disease of small arteries, medium sized artery, and large sized artery. The prototype large size is Takahashi, medium sized artery is polyarteritis nodosa, and the Kawasaki disease, and the small size is pediatric age group is common is Henoch-Schönlein Purpura, which is nowadays called IgA Vasculitis. So, there are varieties of diseases. I am not going to discuss all. There is not possible, and it is not needed to know everything. So, for you, the blood vessel vasculitis, small vessel vasculitis is common in pediatric age groups, Henoch-Schönlein Purpura. Another is Kawasaki disease, the medium cell vasculitis, and the large cell vasculitis I am not going to discuss, Takahashi arthritis, and the musculoskeletal disease is juvenile idiopathic arthritis. That will go. In brief, I will discuss these things. To first start with Kawasaki disease. This is the very common disease, and in pediatric age group, now I do not know how you have been taught to that the rheumatic heart disease was the commonest cause of acquired heart disease. Nowadays in India, it is the commonest cause of pediatric acquired heart disease is called Kawasaki disease. It is not rheumatic, it is replaced by Kawasaki disease. You hardly see any rheumatic disease in near future, but you see very commonly Kawasaki disease. And the second common disease is the vasculitis. This is Henoch-Schönlein purpura. Again, it is a very common, but some people nowadays say it is a KD is most common than the HSP. Some people believe HSP is more common than KD. So hardly matters what is that, but both are common. I am going to discuss these two. Another is JIA. First, begin with this Kawasaki disease. This is Dr. Tomosuke Kawasaki. He described the disease almost 70 years ago. He is no more with us. He once visited in Chandigarh 2005, and this is Dr. Kawasaki, and it is also Kawasaki. Dr. Kawasaki, when described the disease, he was not, actually the Kawasaki disease causes damage to the coronary artery. When Dr. Kawasaki discussed the disease, first described the disease, he was not aware of the fact that it has a devastating effect on the coronary artery. It was this person is Hiroshima Kato. He described the devastating coronary artery disease in Kawasaki disease. Why we should learn Kawasaki disease? Because it causes permanent damage to the coronary artery. And that time in 2003, it is me. I don't know if you recognize me or not. And so that is Kawasaki disease. What is the characteristics of Kawasaki disease? It is acute medium-sized vasculitis, and the causes target artery damage is the coronary artery. Although it can involve any artery, medium-sized artery of the body, but it classically involves the coronary artery of the patient. This is the commonest cause, as I said, heart disease in children, and this is characterized by fever and skin changes. Any pediatric age group patient coming with fever for 5 days or more, previously it is said, nowadays it is said 4 days or more fever with characteristic skin changes, you will have to consider it as a Kawasaki disease. Its common mimicker is the other viral diseases or measles. It's a very mimicker. I will show you one by one. Interesting thing is it is the diagnosis, only clinical diagnosis. There is no pathognomic test is available to diagnose this. You will have to diagnose this clinically, and if you miss the diagnosis, the patient fever and skin changes, what is supposed to appear with the disease will disappear at one point, but it will cause devastating effect on the coronary artery. It is called coronary aneurysm. It may cause myocardial infarction in children. It causes sudden death in the children because of the cardiac involvement. That is not visible from the outside. Once you do not treat at the right time and the right person with the right drug, it causes permanent damage to the coronary artery. That is called kill the patient. In presence of 4 principal clinical features, the diagnosis of complete KD can be made in 4 days of fever. So interesting that any patient coming with 4 days fever, 4 or more days fever with characteristic skin changes, will label it as a Kawasaki disease. So you will have to remember that the 4 days of fever, 4 days or more fever with characteristic skin changes, then you can label it diagnosis as the Kawasaki disease. What are the characteristic changes? I will discuss it later. And there is no pathognomic test, that or diagnostic test that can help you to diagnose. Diagnosis is absolutely clinical, like rheumatic fever. Diagnosis is absolutely clinical. It causes coronary artery damage if you do not treat at the right time. It can damage any artery of the body, but classically it causes damage to the coronary artery disease. Out of all coronary arteries, common side is the right carotid artery, left anterior descending coronary artery. This is the right coronary artery, left anterior descending coronary artery, and other coronary arteries also can, but the commonest side, and the proximal part of the coronary artery is causing damage more than the distal part. That can be picked up with echocardiography. What is the characteristic of fever in Kawasaki disease? The fever is very high grade, abrupt in origin, high grade, do not respond to the paracetamol properly. It will not go down with treatment with paracetamol. Children with KD can live short lasting fever also. Fever usually lasts for 1 to 3 weeks. If you treat or if you don't treat, the fever at one point of the disease will disappear. But it will cause permanent damage to the coronary artery. So what is our main idea is to diagnose it and treat the patient at the right time within the 7 days after the 7 to 10 days after the onset of fever. It should be treated with IVIG. That is the main idea and goal of on teaching you on the Kawasaki disease. Diagnose it, diagnose have to mean clinically, and you'll have to treat you with the IVIG, that is the drug of choice, and aspirin. What are the clinical and there are few classical changes and the criteria that I am coming one by one. So, response to paracetamol, the experienced physician who have treated many patients with KD may be able to diagnose it within 3 days after the onset of fever. That is not necessarily 4 days is required if you have enough experience. Now, what are the diagnostic criteria of KD? We usually follow this criteria. American Heart Association guidelines in 2004 it was given. Now it is 2024 criteria we follow. What is the criteria? Fever persisting at least 5 days with fever. It was previous 2000, now 2024 criteria, it is 4 days or more fever. This is mandatory criteria. At least 4 of the 5 principal clinical features: changes in extremities, acute erythema of the palms of the sole, edema in hands and feet, subacute periangular peeling of fingers, toes in 2 to 3 weeks onset, polymorphous skin rash, bilateral conjunctival injection without exudate. Conjunctivitis with exudate does not occur in Kawasaki disease. Kawasaki disease characterized by the conjunctivitis, non-purulent conjunctivitis, that is no discharge. That is very characteristic of Kawasaki disease. Changes in the lips and oral cavity, erythema of lips, cracking of lips, strawberry tongue, diffuse injection of oral and pharyngeal mucosa, and cervical lymphadenopathy, unilateral cervical lymphadenopathy, not the bilateral. Unilateral cervical lymphadenopathy is the characteristic of Kawasaki disease of KD. And you will have to exclude the other diseases because there are many mimickers and it does not have any diagnostic criteria. So, one by one, at least the mandatory is the 4 days of fever. Greater than 4 days or more fever, but if it is less than 3 fever with other characteristic clinical feature, you can diagnose. What are the clinical features? Mostly seen in the skin. See, you will find the bilateral, it is not unilateral. Unilateral means it is not KD. Bilateral non-purulent conjunctivitis, cracked lips, swollen lips, strawberry tongue, unilateral cervical lymphadenopathy greater than 1.5 centimeter, skin rash. It can have any form of skin rash in Kawasaki disease except vesicular or pustular skin rash. It has not been described in Kawasaki disease. Any form of skin rash they have. Fourth is periangular peeling of skin and other, it is a late manifestations. So that are coming to this, and the erythema of the palms and soles and edema of the hands and palms. This is very characteristic, almost pathognomic and diagnostic criteria. Skin erythema of the palms are usually non-specific, but edema of the hands and feet very characteristic. They may be transient and subside. It may not present all at the time when you are seeing the patient. When you are seeing a day on the 4th day of the illness, many of them clinical features may be there, many of them may not be there. So, if presence is only, if the parents say that I have seen this, you will have to accept it was there or it is there at present. May be found absent when it presents late. This is the characteristic. Skin non-purulent conjunctivitis and here you will find the clear area. From cornea to limbus there will be clear, no congestion. Beyond that there will find congestion. This is very characteristic of KD, and there is no purulent discharge. So bilateral non-purulent conjunctivitis, that is very characteristic of KD. Now see the cracked lips. This lip is the find out, I don't know it is visible from the back bench or not. If you, the lips are swollen and there are cracked, vertical cracked and fissured. These lips are very swollen. This is very characteristic of Kawasaki disease. See the lips is so much swollen, the swollen lips. Strawberry tongue. Erythema of the palms and soles. His palms are visible, not the soles. Soles are visible. Edema of the palms or dorsum of the hand or foot. Very, very characteristic. If it is there in any patient with fever in pediatric age group, you can think of the possibility of Kawasaki disease. Very, very characteristic. It is not diagnostic, but very, very characteristic. Another important is BCG scar activation. Any fever in pediatric age group coming with BCG scar activation, think of the possibility. It is a very, very characteristic sign. It is seen in the first 3-4 days of the illness. It has not been included in the diagnostic criteria, but it is seen in India. Forget it. Now, this is unilateral cervical lymphadenopathy. Now, this photograph taken almost 25 years ago, when it was initially diagnosed as a Hodgkin disease. Missed the diagnosis, biopsy done, and it was labeled as Hodgkin disease. And fortunately enough, and somehow someone did an echo because of he had having cardiac problem. And that time it was picked up that there was an aneurysm in the coronary artery. And retrospectively, when it was found that it is a wrong diagnosis of made Hodgkin disease. And actually patient received a dose of chemotherapy also. Because at that time people are not very much aware of the disease, it was thought a cancer, one size lymph node there, and their biopsy was shown, it is not very clear, but it was labeled at a Hodgkin disease. But for this patient was, when echo was done, because having cardiac problem, echo was done and it was retrospectively diagnosed that it was a Kawasaki disease, missed Kawasaki disease. This is a morbidly formed rash. This photograph was not very morbidly formed. I said any form of skin rash patient can have, except pustular and vesicular skin rash. And it is seen in genital area very commonly. Another part. This is periangle peeling, discommission. See, the skin is discommission of it. It is a very late, it is seen 2 to 3 at the end of first week, maybe 2 to second week of illness. By that time fever may subside, and by that time the patient already has coronary artery damage. That means it's a misdiagnosis. This is the lips are swollen. Discommission of the skin. It's a late manifestation. You cannot allow the patient to go to that stage. When a patient reaches that stage, by that time coronary damage has already occurred. And our main goal is to prevent the development of coronary artery damage. And that if we want to do, we'll have to give therapy or IVIG before the onset of these clinical features. That means within first to 7 to 10 days after the onset of the fever, that you will have to give IVIG. So all patients with Kawasaki disease should be referred to be treated in hospital and should be referred immediately to hospital to give the therapy. After giving IVIG, this is an improved patient. His photograph I have shown, his face and other things I have shown. This has not been described in, included in criteria, but this is very clear. Without diarrhea, perianal discoamation, without diarrhea, perigenital discoamation. This is classically seen in Kawasaki disease. So, I think all of you have come to the point that the patient, any pediatric age is more common less than 5 years of age. Any child coming with 4 days of fever or more fever, 4 cardinal features, all the clinical features I have described is present, then you can label it as a Kawasaki disease. You will have to label it as early as possible within the 7 to 10 days after the before the onset of the disease, so that we can give the therapy. Therapy is IVIG and aspirin, and if you can give therapy, you can prevent the development of coronary artery. The devastating effect it occurs in coronary. If you treat or don't treat, all the clinical features will disappear at one point of time, but it will cause permanent damage to the coronary artery. What are the clinical features? That is bilateral non-purular conjunctival injection, strawberry tongue, cracked swollen lips, skin rash. Any form of skin rash can occur except pustular and vesicular skin rash, erythema of the palms and soles, edema of the palm, dorsum of the hands and foot, very characteristic, but erythema is not that very characteristic. Activation of the BCG scar and unilateral cervical lymphadenopathy greater than 1.5 centimeter, and all of these features we will get in, and the perianal discoamation and discoamation of the skin, then your perianal excoriation, perigenital excoriation. These are the clinical features, classical features. You will get, you will book in, find the criteria will be seen in criteria of American Heart Association criteria of 2024. So, one thing to be kept in, all these features I have described may not be present at given point of time. Some appears in the first day, some disappears in between, some appears in the late, and then by that time all the features appeared, supposed to be in the first part, they have disappeared. So, all the features may not be present at given point. Features evolving over days and weeks are very common. Incomplete presentation are fairly common, which is called say incomplete Kawasaki disease. Kawasaki is classified classical and incomplete Kawasaki disease. So, that when all the features are not there, then we call it incomplete. Overlapping features, other common diseases are extremely common. No specific diagnosis, that to be kept in mind. No diagnostic, absolutely clinical diagnosis. And if you fail to diagnose or treat appropriately, you may place your patient on the top of a volcano. That is the one thing that be kept in mind. That is the reason why I am teaching you. Investigation which may help you: significant neutropenia may be marker of severe disease, thrombocytopenia anemia with onset of জানার দরকার নেই, platelet count is abnormally low. Usually a platelet count is very high, platelet count is seen. Usually at the end of the first 7 days of the illness. At the end 7 days of illness, you may get the very high platelet count. But that is a late manifestation. You will have to give treatment before that. So, I am not going to discuss. Another important is pro-BNP. If it is more than 225 picogram, it is very characteristic of, it is not diagnostic, but associated with increased chance of KD. So, that is to be kept. None of the test is diagnostic, all are circumstantial evidence that the patient may have Kawasaki disease. So, diagnosis is absolutely clinical. Treatment, all patients need to be hospitalized, that to be kept in mind. IVIG 2 milligram per kg single dose IV infusion is the treatment of choice. Along with that, oral aspirin, there are two schools. One school use 5 milligram per kg per day, another use 30 to 50 milligram per kg in divided dose. Till the fever subside, thereafter CRP becomes normal, then it again will have to give a antithrombotic dose of aspirin. This is anti-inflammatory dose of aspirin. This is antithrombotic dose of aspirin, 5 milligram per kg for a prolonged period, depending on the severity of coronary artery disease. It is not that the all of it. If you do not treat the patient with IVIG, then the chance is 30% of a patient can develop coronary artery disease. If you treat with IVIG at the right time, at the right place, right dose, then the chance becomes less than 5%. So if you do not treat, chance of coronary artery damage is 30%. If you treat properly at the right time, the chance becomes less than 5 to 8%. But to keep in mind, less than 10% will be easy to remember. Other drugs used is infliximab, cyclosporin, corticosteroid, anakinra. পরীক্ষা দিলে এইগুলোই লাগবে শুধু। Complication: patient can have shock, patient can have MI, arrhythmia, and sudden death. Sudden death, patient may develop sudden death may come because of the shock, because of the MI, or MI means myocardial infarction, and arrhythmia. Long follow-up requires, depending on the severity of coronary artery damage, at least for if there is no coronary artery damage, and indefinite period if there is coronary artery damage. You may have to follow lifetime. And next is, take home must be Kawasaki disease minded. We have seen patient has a telltale evidence the Kawasaki disease is declared as it is a viral disease, viral exanthem, fever, and the rash disappeared, but patient remained with the coronary artery damage. If I am not wrong, many of you, if is that maybe 1% of one of you have this coronary artery damage. You have heard in adult that suddenly the patient working hard in the gym, suddenly there is collapse and death. There was no predisposing factor of coronary damage, like never had cholesterol, high cholesterol, never had high BP, never had any family history of myocardial infarction, but died suddenly. Thus, this patient's autopsy was done, it was found that he had or she had a coronary artery damage at the young age, and that remained not silent, there was continuous change, and permanent damage to the coronary artery caused sudden death. And no one was aware of it because no one investigated for that. So sudden death in adult, one of the important causes had Kawasaki disease at the young age. That is the reason why we are fighting for it, and we are trying to teach everyone that everyone should at the time of passing of that, what is Kawasaki disease and how to treat and how to diagnose. You do not require anything. When you say do an echo and find the coronary artery damage, then you call diagnosis. Echo is not mandatory for diagnosis. Echo will help you to find out coronary artery. If it is coronary artery damage with fever, you can say it is IVKD, but may not have any change because 70% will have no coronary artery damage. 30%, but you do not know who will develop. So you'll have to diagnose it clinically and you'll have to treat with the patient. So missing diagnosis may be devastating. All KD patients diagnosed to be treated by all doctors. It was not a super specialist disease. All features may not be available in given point of view. I have told you repeatedly. So that is all with Kawasaki disease. Any question from you on Kawasaki disease? Nobody knows why it is unilateral, but it is unilateral. Bolo. Why is the BCR? Could you tell me why is the coronary artery damage? Why the question has not raised in your mind that the coronary artery damage? This is a predilection why someone prefers to eat something. No, there is no reason why he wants to eat a certain things. Similarly, why the coronary artery damage occurs is not known, but it is mainly on the coronary artery. It also causes damage to the systemic artery. The India first case described on the coronary aneurysm of the brachial artery. But here it is common is coronary artery. Similarly, why this activation takes place in BCG scar nobody knows, and why it does not occur in other part of the world also we do not know. It is commonly seen in India. The exact reason is not known. That is the reason. Exact known reason is not known. So if you have this, I have little bit of time and I have to discuss two things. If there is no specific questions of anyone, then I go to the second thing. এই জলটা ভালো না খারাপ রে? হ্যাঁ? আচ্ছা তাড়াতাড়ি এনে দে। Next disease is, I am going to discuss second vasculitis, is the HSP, which is also known as IgA vasculitis. Any one of you can tell me what is HSP? The four last backbenchers of the girls. You have enough time to discuss. এইদিকে ডান দিকে বাঁ দিকে চারটে মেয়ে বসে আছে প্রচুর গল্প করছে। Last backbench, four. Two girls with specs and two girls without specs. Last but one bench. বুঝতে পারছি না বাংলা বুঝিস না ইংরেজি বুঝিস না হিন্দি বুঝিস? Please get stand up, please, please, please. লাস্টে চারজন বুঝতে পারছিস না তোরা কি বলছি আমি? বুঝতে পারছে না? বুঝতে পারলি? I think your response is like that your IQ is less than 30. HSP কি? ক্লাসে ভালো না লাগলে গল্প করিস না, বাইরে না এলেও চলতে পারে। আমরা সবাইকে পাস করাচ্ছি, তোদেরও পাস করাবো, is not difficulty. But only thing at the end of the day you will not become a doctor. You have a degree but not a doctor. HSP কি জানিস? যদি না জানিস সামনে আয়, সামনে চলে আয়। বাংলাও বুঝিস নাকি? বাংলা সামনে চলে আয়। HSP is Henoch-Schönlein Purpura. Both are German names. So Germans were, all the German names have been removed from the literature. So that's why it has changed to become a IgA vasculitis based on pathology. Only this happened with all vasculitis except Kawasaki disease. The name has not been changed. It is still after the name is after the person who described the disease. প্রচুর জায়গা আছে, একসঙ্গে পাঁচজনকে বসতে হবে এমন কোনো কথা নেই। IgA vasculitis, HSP is a non-granulomatous small vessel systemic vasculitis characterized by the deposition of immunoglobulin A complex in the walls of the small vessels. The disease was first described by the person Heberden in 1802. Then Schönlein was the German who described the association between arthralgia and purpura in 1837. Henoch, his student, he described the gastrointestinal manifestation in 1874 and renal in 1899. So it became a HSP. Now that it has been changed according to the Chapel Hill criteria that the no disease will remain anyone after the describer's name. Only the Kawasaki disease is nowadays is still, it has been labeled as described as the describers after the describer's name, that is Tomosuke Kawasaki. What is the, again I am going to discuss all three diseases in pediatric, means today. None have a diagnostic criteria. Diagnostic test all have diagnostic criteria. No diagnostic test is that. You will have to clinically diagnose it. So you will have to become a doctor, only then you will be able to diagnose it and label it. But if you are a fakibaj, you will never be able to diagnose it, and you will kill the patient or the patient will die. If you do not kill, patient will die. The diagnosis is primarily clinical. There are Euler Printo Press classification criteria. মনে রাখার জন্য সোজা হচ্ছে Printo classification. Mandatory palpable purpura. Petechiae predominantly seen on the lower limbs without thrombocytopenia. Palpable purpura without thrombocytopenia classically seen in the lower limbs. It can be seen in other part of the body, but classically seen in the lower part of the body, most common. Plus at least one diffuse abdominal pain, arthritis or arthralgia, renal involvement or histopathology, that is evidence of IgA deposition. Any one of the four, that is gastrointestinal manifestation, but pain abdomen, then arthritis, then the renal involvement or biopsy proven. So biopsy is not mandatory, and the mandatory is palpable purpura. Now my question is, anyone can tell me what is palpable purpura and what is purpura? Anyone? Volunteer? Anyone can volunteer? কেউ volunteer করার মতো সাহস নাই? What is the normal size of purpura? Anyone can tell me? Huh? মনে রাখার জন্য 1 to 2 millimeter বলা হয়. It is difficult to say how it is pin head. Any pin পাওয়া যায়, পিনের হেডের যে সাইজ, that is hemorrhagic spots are, the size is that, and the bleeding under the skin, that is hemorrhage, that is purpura or petechical. So size is pin head size, that is 1 to 2 millimeter, and it is under the skin. And if it is raised from the skin, then it is called palpable purpura. And palpable purpura is a manifestation of vasculitis, small vessel vasculitis. So that is the palpable purpura classically seen in SLE, palpable purpura classically in Henoch-Schönlein purpura or IgA vasculitis. So that is palpable purpura which is palpable clinically. সবাইকেই মশা কামড়েছে, everybody has been bitten by mosquito, which you see is that is the palpable purpura. That is not palpable purpura, that is a inflammation that is usually raised, but once you press that mosquito bite, it will disappear, but purpura will never disappear. So if it disappears, it is a mosquito bite, and if it remains and does not blanch with the pressure, then it is purpura. And if it is raised from the surface, it is palpable purpura. If it is not raised from the, it is called petechical or purpura. So that is classical. So clinical diagnosis, skin rash, that is palpable purpura, classically seen in the lower part of the body, and any one of the four, that is the pain abdomen, arthritis, and the renal involvement, commonly seen hematuria, and the fourth is the histopathologic histopathology proven IgA vasculitis. So that you can label it as a Henoch-Schönlein purpura. These are the palpable purpura in the lower limb, classically seen in lower limbs and buttocks. Then you can, from the photograph you can see that they are raised, and sometimes there is all the purpuras may coalesce together and মিলকে রাখে wide ecchymotic lesion এর মতো. So that is also manifestation of HSP. This is the old purpura, and if you want to take the biopsy, you will have to take the biopsy from a fresh one, that is within 48 hours after the appearance of the purpura. Otherwise it will not give you the right histopathological finding. What investigation you can do? You do not require any investigation to diagnose. Diagnosis is absolutely clinical. What you require is to rule out the few other diseases and also to rule out the complications. What are the complications they can happen? One thing is the gastrointestinal tract. They can have gastric hemorrhage, they can have gastric hemorrhage, infarction, intersusception. Intersusception is very common in case of HSP. Gastric hemorrhage, perforation, pulmonary hemorrhage, stroke, orchitis, these are the complications also can have the patient with, and the most dreadful is the renal failure, renal manifestation. These are the complications that can happen with HSP. So that you will have to investigate to rule them out. Then you do the CBC to exclude thrombocytopenia. The diagnostic criteria, there should be no thrombocytopenia. SLE তে thrombocytopenia থাকে, palpable purpura with thrombocytopenia, but এখানে থাকে না। ESR CRP usually mildly raised or not very raised. Urinalysis to hematuria, proteinuria to as the clinical criteria. Renal involvement characterized most commonly by hematuria. That's why you will do an urinalysis. Renal involvement is there or not to see for the renal function test. Serum albumin to see that the hypoalbumin is there or not. They common with renal involvement, common with raised blood pressure. So blood pressure monitoring important. Stool blood to see there is any hemorrhage is occurring or not. Ultrasound abdomen, if the patient is complaining of severe ultrasound, to rule out intussusception. In intussusception, you will get target sign in ultrasound, then we will tell you that the patient is going to develop intussusception. Before the development of intussusception, if you treat with corticosteroid, then can you reverse the intussusception. Otherwise, you will have to do surgery. So that's why you will have to pick it up early in pain abdomen, and with the help of ultrasound, you can do that. Renal biopsy is not required when there is renal involvement. So to diagnose HSP, you do not require any investigation, you just require to rule out the complications. What are the complications that I have told you? Complex intussusceptions, gastrointestinal hemorrhage, perforation, orchitis, severe renal involvement. These are the major complications. Others I have said stroke, pulmonary hemorrhage, unconsciousness, all this can happen with HSP. But these are the commonest. Management, simple. There is no specific therapy is required. They are self-limiting disease and require symptomatic treatment. Most of the situation, what you need is the reassurance, most self-limited, adequate hydration, rest, paracetamol for pain, and sometimes non-steroidal anti-inflammatory drugs even if there is more pain, because they do not cause any gastrointestinal hemorrhage in this. Corticosteroid is sometimes have been used, but this is not a medicine of choice. This is not any treatment therapeutic. It is used only to prevent intussusception and when there is severe skin manifestation and pain abdomen. In these situations, we use corticosteroid. Moderate to severe abdominal pain, severe arthritis, scrotal edema, extensive edema, suspected severe skin disease. Most common is moderate to severe pain, intussusception and selected severe skin disease. Prednisolone is given 1 to 2 milligram per kg. It should be given for a longer period, otherwise there may be reversal of symptoms or recurrence. Note, steroids improve joint and abdominal symptoms rapidly but do not reliably prevent IgA Vasculitis. That is, you do not have to know all these things. Next is, it causes renal involvement. 20 to 25% patient children can develop it, but severe renal disease occurs in less than 1%, in 90% in 90 days. So what you will have to do, they will have to, patient can initially may not have renal involvement, over 90 days period he can develop. So you will have to follow for at least for 90 days. That extended period, that means you will have to follow for 1 year. That is the criteria. Renal failure, hypertension can develop 10 years after the onset of disease. So one thing is that renal failure may not be present at the beginning of the disease. It may occur 90 days after the onset of disease. That's why all the patients with HSP has to be followed for a longer period of time, depending on the severity of renal involvement. If no renal involvement, after 1 year you can discharge, you can remove from the follow-up. Recurrence 50% হতে পারে, কিন্তু এইটুকুই জেনে রাখো, আর দরকার নেই, এটাও জানার দরকার, ডিসকাস করে দিয়েছি। Surgical management sometimes require if the patient develops gastrointestinal hemorrhage or intussusception or bowel perforation. Required combination intussusception, bowel perforation, massive gastrointestinal hemorrhage. Follow-up, monitor blood pressure, urinalysis and renal function test. Suggested schedule, weekly for the first month, then every 2 weeks during the first 2-3 months, then monthly after 6 months, every 3 months for 1 year, continue longer if urinary abnormalities persist. keep it in mind, they may develop late, so that has to be followed up at least to be 1 year. But if there is renal involvement, you will have to follow up for a longer period. এত এক মাস অন্তর 2 মাস অন্তর এত মনে রাখা, no need to remember, just you remember it that it need to be followed up for a longer period of time. Prognosis is good, majority of situation, 90% recover completely, relapse occur 25 to 35% of patient. Long-term prognosis determined mainly by the severity of the renal involvement. If there is renal involvement, prognosis is not good that enough, but majority 90% it is good and self-limiting. So, HSP is a small vessel vasculitis. There is no diagnostic test. It is absolutely clinical. Clinically, there is characterized by the mandatory criteria, Euler or Press criteria. Mandatory criteria is the palpable purpura without any thrombocytopenia out of 1 and 4, that is arthritis, abdominal pain, renal hematuria, renal movement, or the biopsy proven IgA Vasculitis. This is diagnostic. Majority is palpable purpura occurs in the lower part of the limb, and it is then I have shown the figure, and the tests are done to rule out the complications. That comes ultrasound, after there is severe pain, CBC to rule out the other causes, CRP, ESR, and the urine to see that there is renal involvement or there not, renal function test to do the renal, whether the patient having renal involvement or not, and if sometimes biopsy if it is required. Otherwise, it should not be done. Treatment as mostly symptomatic, hydration, control of fever, or control of pain abdomen. You may use with paracetamol or non-steroidal anti-inflammatory drugs. You may use corticosteroid if there is severe pain abdomen, arthritis, or there is any gastrointestinal hemorrhage. Otherwise, and it does, corticosteroid cannot prevent the renal involvement. Patient can have renal involvement at the beginning of the disease or any time between the 90 days after the onset of the disease. So, the patient needs to be followed up for a longer period. If it is renal involvement for an indefinite period, you will have to follow up. Prognosis is good if there is no renal involvement in 90% situation. If the renal involvement is there, then the prognosis is not that good. Less than 1% situation, it develops a chronic renal failure or long-stay renal failure. That's all. And surgical management rakhe jokhon when there is interstitial gastrointestinal hemorrhage or perforation. That's all. Okay. Next is our juvenile idiopathic arthritis, the last thing. Again, the diagnosis is clinical. There is no diagnostic test. All tests we do here to rule out complications or to level the subtypes. Juvenile idiopathic arthritis is an arthritis of chronic in origin, inflammatory variety, and it may be fasciarticular, means less than 4 joint involvement or more than 4 joint involvement. Juvenile means less than 12 years, and idiopathic no known etiology. So, no known etiology, less than 12 years, chronic inflammatory arthritis, polyarticular or fasciarticular, means polyarticular means more than 4 or 4 or less is fasciarticular. So, before leveling it any patient with juvenile idiopathic arthritis, you will have to learn what is chronic arthritis and what is inflammatory arthritis, and last is what is arthritis. Now, what is named question is arthritis, what is joint? Anatomy সবাই পাস করেছে, জয়েন্ট মানে কি বলতো একটু দাদা? What is joint? Joint consists of what? Anatomy question. বল তাড়াতাড়ি বল, সময় নষ্ট করবি না। হ্যাঁ, জয়েন্টে কি কি থাকে? হ্যাঁ বোন, হ্যাঁ জোরে বল। টেন্ডনস, কার্টিলেজ। টেন্ডনস বাইরে থাকে, ইন্ট্রা-আর্টিকুলার লিগামেন্টস থাকে, আর synovium, capsule, synovial fluid. Okay. So, articular surface, articular cartilages, intra-articular ligaments, synovial, synovial fluid, and capsule. So, most of all, disease of anything can give rise to arthritis, that is joint pain or joint involvement. Again, there are structures which are outside the joint, known as periarticular structure. What is periarticular structure? They are nerves, that is the skin, overlying skin, fascia, bursa, ligaments, muscles, adjacent bones to the structure, and one may miss bursa, extraarticular ligament, muscle, tendons, fascia, nerves. So these are the structures which are periarticular structures. Disease of any of them also can give rise to joint pain. So you'll have to clinically differentiate what is arthritis, what is non-arthritis, a periarticular structure involvement. Again, arthritis and arthalgia. Pain in the joint is called arthalgia. Pain in the joint is, but when it is swollen, it is called arthritis, and restriction of movement is called arthritis. Swollen and restriction of movement is arthritis, only pain is arthalgia. So that is not arthritis, and you can have joint pain in both periarticular structure involvement and articular. Then first thing you will have to differentiate, is the patient suffering from arthritis or patient is suffering from periarticular structure involvement. How to differentiate? Joint pain usually deep seated, but periarticular is superficial. In joint pain, patient will not be able to say where is the pain, it's only ekhane ekta ache, kintu in periarticular particular site they can localize where it is. So patient will be able to localize. Periarticular structure, there pain is, when it is active movement there is pain, there is no movement pain in the during passive movement. In articular there is restriction of movement. In periarticular structure there is no restriction of the joint movement. So that way you will have to differentiate between articular and non-articular. And articular joint involvement, there will be deformity of the joint, and there may be subluxation, damage to the joint, or there may be sometimes the crackling sound is heard, especially in adult, not in pediatric. So pain, deep and superficial, active passive movement are restricted. Active movement is restricted in non-articular. Both pain movement, both active painful, localized or diffuse, localized, deformity is present in articular involvement, no. Crepitation of subluxation is seen in articular. So articular pain is deep seated, active passive movement is restricted, pain both during active pain movement, diffusion, the patient will not be able to, deformity is common. So that way you can differentiate between articular structure involvement and non-articular structure involvement. So this is arthritis. When arthritis presents more than 6 weeks, we call it chronic arthritis. When it is less than that, we call it acute arthritis. I am in hurry, I am skipping it, it has somay lagbe. And inflammatory and non-inflammatory, how will you differentiate? Inflammatory, the pathology they put cardinal, hot, inflammation means hot, swollen, tender, and hot, so red hot, swollen, tender. Red hot, swollen, tender, these are the 4 manifestations of inflammation. When there is inflammatory arthritis, all these features will be present. In non-inflammatory arthritis, no features will be present. They will be associated with fever, sometimes other organ involvement, target organ, systemic manifestations like stiffness, fatigue and weight loss, elevated acute phase reactants. These are the characteristic feature of inflammatory arthritis. And the stiffness is the morning stiffness is a very characteristic of arthritis of juvenile arthritis. Morning stiffness, আমাকে কিন্তু সময় নেই আমি describe করতে পারছি না, clinic class এ describe করে দেবো. So right side এটা হচ্ছে inflammatory arthritis, এটা হচ্ছে non-inflammatory, কোনো red hot swollen tender নেই, এটা কিন্তু red hot দেখা যাচ্ছে, হটটাকে ফিল করতে হয়, এটা হচ্ছে inflammatory arthritis, it is non-inflammatory arthritis. So juvenile arthritis is a chronic arthritis and inflammatory arthritis. এইটা কিন্তু juvenile arthritis নয়, এটা দেখেই একটা মেয়ের হাতের ছবি, মেয়ের আঙুলে আংটি পড়ে আছে, এটা জুভেনাইলের মলো, কিন্তু ইনফ্লামেটরি নয়, এটা অন্য ডিজিজ থেকে হচ্ছে, সেটা আমি জানি না। এটা হচ্ছে একটা ছোট বাচ্চার ছবি, এটা ইনফ্লামেটরি আর্থ্রাইটিস। So acute chronic, more than 6 weeks it is chronic. Acute arthritis commonly seen in trauma, infective, reactive and crystal induced. Acute monoarticular arthritis is a medical emergency. Most common cause is the septic or trauma. Whenever you will find any acute monoarticular arthritis, refer the patient immediately to the hospital. It is a medical emergency. Acute monoarticular arthritis, either it is due to trauma or due to infection. Rheumatic arthritis never passes beyond 8. Rheumatic arthritis is not a chronic and it is acute arthritis, and this is non-migratory. Yes, JIA is a non-migratory additive arthritis. Agari bole diyechi non-inflammatory ekhane kothay nekhini. It's a non-migratory additive bilateral symmetrical arthritis. So JIA, chronic inflammatory arthritis, non-migratory, additive, bilateral, symmetrical arthritis. So these are the features. When you present in a child with a less than 12 years of age, then you label it as a juvenile atopic arthritis. When it is single joint involvement, it is called monoarticular. When it is 2 or 4 joints, it is oligoarticular or polyarticular. When the more than joint is polyarticular. Depending on that, you will label the diagnosis, subclassify you. That is absolutely clinical, 12 years, chronic, symmetrical, without any known etiology. There are 6 subtypes. Polyarticular, if rheumatoid factor is positive. We do not do rheumatoid factor to diagnose it, to label it, what type of subtype is suffering from. That means, if it is positive, then it is polyarticular rheumatoid factor, polyarticular rheumatoid factor negative, polyarticular enthesitis related arthritis, systemic arthritis, psoriatic arthritis, and unclassified. These are the subtypes of the disease. Ami ekta miss korechi, subtypes of the disease that we will call label it. If it is positive, chatte jointer besi involvement ache, that is polyarticular, it is rheumatic factor positive, rheumatoid factor positive polyarticular arthritis, rheumatoid factor negative polyarticular arthritis, polyarticular arthritis, enthesitis related arthritis. If it is systemic onset, systemic arthritis. What is the treatment? Non-steroidal anti-inflammatory drugs. We use commonly naproxen 15 mg per kg, 15 to 20 mg per kg per day in 2 divided dose. We use methotrexate oral or weekly 10 mg per meter square. Weekly, once in a week, every week. We will use occasional corticosteroid to improve the response, but corticosteroid is not a drug of choice or should not be used regularly. And if it patient do not respond to this first group of drugs, then we use biologics. Commonly used TNF inhibitor like etanercept, infliximab, tocilizumab, and sometimes JAK inhibitors like tofacitinib. So these are the first 3 drugs is the commonly used non-steroidal anti-inflammatory, methotrexate, occasional corticosteroid, and when patient do not respond to it within 3 months after the onset of disease, then we use anti-TNFs, etanercept, infliximab, tocilizumab. I am not going in detail, there is no need to know it, and sometimes JAK inhibitors.